Good afternoon, everyone. Thank you for participating in this accredited activity. You can access the CME information for this activity, including details on how to claim credit, via the QR code that appears on your screen or the link posted within the chat box. A link to our resource page, which includes all journals we will be discussing today, can also be found in our chat. Today's presentation, Empowering OBGYNs, Leading the Way in Postpartum Depression Care, is part 2 of a 3-part series. If you are interested in viewing part 1, please see the link in our resource page. So I would like to introduce our faculty, and I will begin with our first speaker, Dr. Aljoy Baker, who is a board-certified obstetrician and gynecologist in LaGrange, Georgia. She currently serves as Director for Quality and Safety for Women's Health and is Vice Chair of the Department of OBGYN and Pediatrics at Wellstar West Georgia Medical Center. Our other faculty member is Dr. Cipra Latta, who is the co-founder of Luna Joy and an adjunct professor of psychiatry at Emory University School of Medicine. She is also a psychiatric consultation line advisor at Postpartum Support International in Brookhaven, Georgia. If you have any questions during the session, please post them in the comments, and our presenters will be glad to address those questions or concerns at the end. I will now turn over the presentation to Dr. Baker to introduce the articles for today's discussion. Dr. Baker,
Thank
thank you
you,
so much.
Georgiana. I am so delighted to be back with you guys for session 2 of this very timely discussion. Today, we are going to be talking about some journal articles here that you see listed on the screen. The first one is about treatment and management of mental health conditions during pregnancy and postpartum. This is the ACOG clinical practice guideline number 5. And then we're also going to be talking about zuranolone and brexanolone for the treatment of postpartum depression. And then our long-term maternal-child outcomes following the postnatal SSRI treatment. So these are some really important articles to note if you are taking care of pregnant patients. I'm going to just give a little brief recap from our previous session where we talked about screening. So some of the validated screening tools that are available are the PHQ-9, the Edinburgh postnatal depression scan, and the GAD-7. And so ACOG has recommended that we're screening at multiple encounters, mainly at the initial prenatal visit. Later in the pregnancy, usually around 3rd trimester, I like to do this at that 26 to 28 week glucola screening, where I have the patient there for an hour anyway. So we have plenty of time to do surveys and talk. And then the postpartum visits should certainly be accompanied by routine screening so that we decrease stigma and sort of normalize the importance of talking about mental health conditions during and after pregnancy. So a critical point is that a positive screen does require us to have a system in place for how we are going to have a brief intervention with that patient and our plan for referral to treatment and follow-up. ACOG explicitly warns against screening without treatment capacity. And I know this sometimes makes it a little bit intimidating for many specialties who don't happen to be psychiatrists, but it is very easy to set up a program for how you're going to plan to refer these patients and sort of a routine way of having conversations with patients about mental health. So let's go ahead and move on to the clinical guidance about treatment. So here's our first article, the ACOG practice guideline number 5. Uh-oh, I think I advanced the slide too fast. Okay. Oh, There we go. All right. Mental health conditions should definitely be treated in pregnancy and postpartum. And I think the vast majority of us are aware of that. Discontinuing psychiatric medications only because of pregnancy is certainly not recommended. It's very important that if patients have been dealing with mental health conditions, that we continue to keep them stable on their meds and to seek some advice if we're worried about a particular medication. And we can do that from our reproductive psychiatric colleagues or from our um, maternal fetal medicine specialist colleagues. So shared decision making is the term of the hour, helping patients weigh the risks and the benefits and thinking about the decision that they need to make in terms of how they want to receive their care. There is certainly a risk of untreated illness, and then there can be risk of medication use. And so it's very important to have that shared decision-making conversation with patients to talk about the patient's values and preferences. But, we need to treat perinatal mental health just like we would any other chronic medical condition in pregnancy. It is very important for us to screen for it, to come up with a treatment plan, and to help that patient move forward. So I see that Dr. Lotta has joined us. Welcome, Dr. Lotta. And I would love to have you kind of take over here and talk a little bit about the ACOG treatment recommendations. Let's see, we may have lost her. So I'll keep going until we get her back. But ACOG recommends that we are treating these patients in the perinatal period. So for those patients who are reporting with mild symptoms, this is usually going to be anywhere from, Edinburgh postnatal depression scale of say 7 to 13. Those patients are great candidates for cognitive behavioral therapy or other psychotherapy components. Once they reach the moderate depression scale, which usually is considered around 14 to 19 from the Edinburgh postnatal depression scale, then antidepressant therapy can be considered for persistent symptoms. And of course, psychotherapy is always a great partner to any sort of medication therapy. When we reach moderate to severe depression, like from, say 20 and above on the Edinburgh postnatal depression scale, we definitely want to be encouraging pharmacotherapy along with psychotherapy. And psychotherapy and pharmacotherapy sort of go hand in hand. And it's very important that that patients are offered psychotherapy along with pharmacotherapy because they are very synergistic in the way that they improve the patient's outcomes. And then, of course, if you have severe or refractory illness that's not responding to pharmacologic options, then psychiatric specialty care is recommended. So the goal is always to enter remission and get to a functional recovery. So I see Dr. Lotta is back with us. Dr. Lotta, it's great to have you. Welcome. Dr. Lotta is our psychiatric colleague here, and I would hand it off to you to talk a little bit about pharmacologic treatment as per ACOG guidelines.
Absolutely. So ACOG is very clear that when it comes to pharmacologic treatment, there is a clinical emphasis on using SSRIs as needed. SSRIs typically tend to be sertraline, escitalopram, and fluoxetine. The most important thing to remember when choosing an SSRI is to use what has typically worked in the past. So typically, if someone has already been on an SSRI, sertraline, escitalopram, or fluoxetine has been the treatment of choice, then it's always good to go with what's worked. And if not, if something hasn't worked in the past, these are considered safe medications to utilize. Sertraline is the one that we typically have the most evidence base on, and especially during breastfeeding is considered safe during breastfeeding. So This is the preferred tried and true one. We try to avoid switching medications unnecessarily because that's more exposure to the baby. However, if a medication is not working, it is important that we either increase the dose or we switch to another agent that's working. We don't want to continue to give a medication and expose mom and baby to medication that is not working. And then we want to use the lowest effective dose, but avoid under treatment. So it's really important that we optimize the dose. We can go up slowly, but we want to make sure that we are effectively treating symptoms. The other thing that we want to avoid is keeping someone on a low dose that is not therapeutic. So then again, we're not getting the benefit of the treatment and we're not getting the benefit of the medication while still having that exposure.
Yes, I love that, Dr. Lotta. I talk to patients about that all the time. They'll say, "Oh, just give me a low dose." And I'm like, our goal is to treat until remission, until your symptoms are much better. And so, making sure that we're getting them to therapeutic doses, I think is very important. You don't want to expose the pregnancy to, you know, a low dose of medication and the mental illness at the same time. We want to, do one or the other when we talk about shared decision making. So I'm really excited that you said that. I want to talk a little bit about the long-term maternal child outcomes following postnatal SSRI treatment. So this was a really large study that was done. There were over 60,000 postpartum folks involved in this study. The focus was on maternal depression and child development. And so what they found in those patients who had actually been treated with the postnatal SSRI was that there was certainly a decrease in the maternal depressive symptoms over time, and there was an increase in the maternal functioning, which is very important. Postpartum depression can be marked by the inability to function adequately for some moms. And so definitely a very important time because there is a lot of maternal fetal bonding that's happening in those first 6 months. So that mom really needs to be functioning well and to be able to be available to her infant, to be able to do those bonding exercises that are so important in those first 6 months. And the most important thing to note from this study was that there was no significant long-term increase in adverse neurodevelopmental outcomes in children. So, that's a huge deal. So this study just makes it easier for us to feel really comfortable prescribing SSRIs, but what about patients who might not be a great candidate for SSRIs or who have not been helped with this treatment? Dr. Lotta, can you talk a little bit about other options that we have available in that case?
Absolutely. And so this brings us to our third article, and this is from the January 2026 edition of the Journal of Obstetrics and Gynecology regarding two new drugs that are the first drugs that are specifically developed for postpartum depression. It's a really exciting time in reproductive psychiatry. And so for patients that an SSRI is either not first line, has not worked in the past, they've had treatment resistance, some things that we can think about is this new class of medication that are targeting GABA A receptors. And the mechanism of action is through postpartum hormone withdrawal, which is what disrupts GABAergic signaling. That's often the neurosteroid that restores inhibitory signaling. And so two therapies have been reviewed and developed. One is brexanolone, which is not available in the US as of January 2025. We're not going to go into detail on that today. And then we'll talk about zuranolone next. So from zuranolone, it's an oral neuroactive steroid. The real benefit of the medication, why we think about it being really powerful and exciting, is that it is a 14-day oral course, unlike SSRIs, which typically you start and people need at least 2 to 4 weeks to start feeling effect. Typically, we say 6 weeks until we really start to expect effect from an SSRI. This is a 14-day oral regimen. It is rapidly said to improve depressive symptoms. Again, we're not talking about 6 weeks, we're talking about days. And we see sustained improvement after treatment course. So, especially patients that have really significant depressive symptoms, especially when they're having suicidality, other things that are suicidality, they need to potentially be in the hospital, but there's a lot of suicidal ideation without intent, without a plan, things like that. But we're really worried about them. We really want to be very quick in treating, and we want to see a quick remission of symptoms. This could be an option. And some advantages is this can be done outpatient. It's exciting to have a tool that can be utilized quickly, administered quickly, and that we can see results from quickly. However, the downside with zuranolone is it's a newer medication. We're still uh, it- getting it out to the individual patient can be a little challenging. Not all psychiatrists prescribe it. There's still some barriers with getting into the hands of patients, and then it does have sedation, which can be problematic, and also contraception is recommended during treatment. There is an FDA back box warning, as actually do exist with SSRIs as well, which is that it can increase suicidal thoughts and behaviors. And so we really do want to make sure that there's adequate oversight and monitoring. And so, Dr. Baker, now that we've reviewed kind of our treatment options, tell me a little bit about how you discuss these treatment options with patients.
Sure, I'll be happy to do that. So when I talk about medication risk, I always want to talk about, those risk versus the benefits. So we, generally start out talking about, sort of the pathophysiology about what's going on, what's happening to you. And so I'll talk often about, maternal stress, anxiety, and depression, and how that dysregulates the HPA axis. And it really can increase cortisol levels, and that stimulates preterm birth because it sort of almost creates a hostile environment within the intrauterine environment. And so when you see those elevated cortisol levels, we can see a decrease in birth weight. So babies can be born with low birth weight. There's a dysregulated immune response, which can increase the risk of preeclampsia and abnormal placentation. And then you can see, different physical and mental illnesses. One is hypertensive disorders of pregnancy. And, those things can be very, they can sort of derail a healthy pregnancy. And so one of the things that I talk to patients about is not exposing the pregnancy to mental illness. I think it's very important to be treated with pharmacotherapy or psychotherapy or a combination of both to make sure that we are setting ourselves up for success. In addition, when there are mental health conditions that are untreated and unchecked, then we run the risk of having folks who are just not able to engage in the prenatal care space and in routine screenings that help us keep mom and baby healthy. So I tend to take the opinion that mental health in pregnancy is probably one of the most important things that I'm screening for and treating because it affects all of the downstream potential adverse outcomes that can happen in pregnancy. So I always like to make sure that I'm focusing on that. And so, after delivery, we can see impaired bonding with baby. And then there's also those risks for suicidal ideation. So, Dr. Lotta, what insight can you add to engaging patients in treatment for depression? Because that can sometimes be difficult when folks are worried about treating depression while they're pregnant or breastfeeding.
Yeah, absolutely. I think this is really one of the most critical discussions to have with patients. And the first thing is you always want to engage in shared decision making. We want to emphasize patients having a sense of agency and being able to take control of their treatment. And the best way for patients to take control of their treatment is for them to be equipped with data, with facts, and with knowledge so that they can make a truly informed decision. The first thing we really always want to emphasize is medication can seem very scary during pregnancy, but the risks of medication, especially SSRIs during pregnancy, are generally small compared to the risks of untreated illness. And I think that this is something we don't often talk about a lot, which is Dr. Baker's just done a really good job talking about the risks of untreated illness. And so when people think about what are the risks of doing something, they should also be aware and be counseled of what are the risks of not doing something. And so, some small risks we think about are neonatal adaptation syndrome that can occur, but symptoms are usually mild and self-limited. And really, the treatment goal for both mom and for physician and practitioner should be to prioritize maternal stability and mental stability. So, Dr. Baker, can you kind of pull this information together for our audience today and start to go through a bit of a summary on what we've reviewed here?
Absolutely. So our goal as physicians and scientists is always to translate the evidence that we find into how we practice. And so the best practices for pharmacologic treatment include treatment of perinatal depression actively. So this is not something that we want to sort of sit on and say, okay, well, we'll check in after delivery, or we'll check in 6 weeks postpartum. We want to be active in screening for and treating these conditions. SSRIs remain the first line pharmacotherapy, and Dr. Lotta so adeptly talked about fluoxetine, escitalopram, and sertraline as some of the first line agents. And then if we are considering the emerging therapies, those neuroactive steroids like zuranolone provide rapid symptom relief. Many patients see symptom relief that's statistically significant by day 3 on these medications. So for those patients that you are concerned about, that you think really need urgent intervention, should definitely consider the zuranolone that we discussed earlier. And zuranolone can also be used as an adjunct therapy. So if you have patients that are already on SSRIs during the pregnancy because they've been dealing with major depressive disorder or other mental health conditions, you may think about adding zuranolone to fill the gap for folks with severe symptoms that may need a little extra. And so, to drive home this discussion, I think that shared decision making is key. Patients really need to be engaged and involved in making the decision for treatment and what type of treatment that they're open to and willing to participate in. I always try to encourage psychotherapy along with pharmacotherapy just because of their synergy and how they improve outcomes for the patient. And also, I want to emphasize that, empowering the patient and helping them understand the options can be a really good tool for patients sort of taking ownership of this and saying, hey, I want to feel better. Here's what I'm going to do. So, I think we've got about 2 minutes left. Are there any questions from the audience?
We do, Dr. Baker, we do have a question. And this is probably one for you. It says, I have a patient who clearly has depression at a level that would benefit from treatment, but they refuse to even consider medications as they are breastfeeding. How can I have a respectful conversation with my patient that addresses these concerns?
Oh, okay. That sounds like a great question. And I can tell you from experience in my practice, I talk about this a lot with patients because a lot of times patients are very anxious and afraid of starting medication during or immediately after pregnancy when they may be breastfeeding. So we actually talk about the risk of untreated illness. And then I also will bring out some data, some information. I have a little chart that I use that looks at the different SSRIs and the relative infant dosing. Relative infant dosing is basically how much of a medication makes it into the breast milk when people are lactating and taking medications. And so there are several medications that have a fairly low relative infant dosing in breast milk. So I always kind of talk about that. And then we talk about the benefits of actually treating mom and for her to get to a better mental state, but also to improve her functionality and so that she's fully available to really bond with that infant and to be able to get back to feeling like herself, to be there for her family, but also just because her mental health and her stability is very important. So I talk to my patients about that. Many times people are delaying decisions because they're worried about the effects on the baby, but I also tell her that she is worthy of feeling normal, feeling like herself, and that we don't have to sacrifice everything for the baby, and that, it's very important for her health to be intact as well. So thank you for that question. I think that's, something that we can always sit down and talk to our patients about. And many times patients are often willing, once they understand a little bit more about the benefits of treatment and what exactly the amount of that medication that appears in breast milk.
Great answer. Thank you, Dr. Baker. And I think we are about to the end of our time. So, Dr. Lotta, I'm going to go to you and give you the final word today before I review our CE information with our audience.
Absolutely. So the really important final overall takeaway is the evidence increasingly supports aggressive treatment of maternal depression to improve outcomes for both mother and child. And so this is not something that we want to watch and wait. This is something we want to intervene on as soon as we're seeing symptoms and do shared and joint decision making with our patients with evidence-based treatment. I would like to invite you all to the next journal club on May 12th, where clinical scenarios will be explored, and it'll help us as physicians integrate depression screening and treatment into the pregnant and post-delivery birth persons.
And that sounds like it will be a great session, and I hope everybody can join us as well. Just some final things with our CE credits. To receive credit for today's presentation, please scan the QR code that you see on your screen to complete the evaluation. The link is also found in the comments section, and then upon completion of the evaluation, you will be able to download your CE certificate. We really thank you for your presence today. Thank you to our audience, our listeners, and especially to our faculty for sharing this important information with us about postpartum depression and its appropriate treatment. Thank you so much. Have a great evening.